My name is Dr. Aisha Delaney-Brumsey. I am the Chief Strategic Growth Officer at Fountain House, and I'm very excited to be your host for episode 129 of the 988 Crisis Jam. The featured presentation today will be with Dr. Richard McKeon from SAMHSA, talking about the National Strategy for Suicide Prevention. So welcome, everyone. Thank you for being here. As always, for people who are longtime attendees, but also for new people, all of the information about the Crisis Jam is on this website, talk.crisisnow.com. It is also going to be likely in the chat, but if you want to go here, you get the Zoom link, you get previous sessions, you get the news articles. Really, this is a resource I use all the time in my day-to-day work, and I send it to my colleagues all the time. I know many of you in this room do similarly. Next slide. So in addition to the website, there is also a YouTube channel, and there you can get many of these Crisis Jam, including the top 5 episodes that you can see right here, but also some of the older episodes when fewer people were attending. So go ahead and dig into those archives to catch up either on the most popular or on episodes that you might not have seen. It's a great resource. Next slide. Really excited that coming up in just a little over a month and a half or so is episode 135, where 988 turns 1, and we will be with Monica Johnson from SAMHSA for that episode. You know that we do here at the Crisis Jam the launch of 988. You know that the 1-year anniversary is also going to be big, so definitely tune in for that episode. Next slide. Another important piece of news today is that, first of all, I have to do a big congratulations to Dr. John Palmieri, Richard McKeon, and James Wright of SAMHSA, because they have made it into the top 12 for the Partnership for Public Service honorees. And everyone in this room can make sure that they are winners. So I believe there will be a link in the chat, but you can vote today. And you can vote again tomorrow, but make sure to do it today to ensure that we are honoring some of the great work that they have done and that we have all been able to learn from and support throughout this Crisis Jam and over the last several years. So congratulations to everyone for making the top 12. In addition, an important piece of news is that DOJ and HHS, about a year ago, the president issued an executive order on advancing effective accountable policing and criminal justice practices to enhance public trust and public safety. A mouthful. However, it's a year anniversary of that, and they have released not just additional guidance, but like guidelines on how to go about doing that work that's outlined in that presidential executive order. And it's a joint guidance from both DOJ and HHS. It's great to see some of that collaboration at the federal level, which is so important for making sure that our systems, both federal, state, and local, are working well together. So definitely check that out and see where the feds are moving. Next slide. The Kaiser Family Foundation, you can also find this article in the news, but also in the chat, has focused on which states have Medicaid coverage of care for the core 3 crisis services, someone to call, someone to come to you, and a place to go. And you can see dark blue, places like Arizona, all 3 core crisis services are covered. Orange places like Florida, unfortunately, none of those services are covered. So take a look at that, see where your state falls, see how that fits into your advocacy around crisis care and the continuum of care. Next slide. Then I believe now I actually do have Tracy Velasquez from Pew to talk a little bit, just a minute or so, on this article from Pew around 988. Tracy, so good to see you. Welcome.
Nice to see you. Can you hear me okay?
Yes.
Great. Well, thanks so much for having me on. Last month, Pew had Ipsos Public Affairs include a few questions about 988 on their nationally representative survey. which was done as part of our mental health and justice project. The survey showed that 13% of people had heard of 988 and knew its purpose. People who identified as white, having a higher income, or having greater educational attainment were the most likely to have heard of 988. When provided with a description of 988 and its purpose, about 72% said that they were somewhat or highly likely to use the service, but many had concerns. About 2 in 5 people were concerned that law enforcement would be sent, they would be forced to go to the hospital, or they would incur costs that they couldn't afford. So we know that SAMHSA has recently expanded their support of 988, including helping states and localities with their outreach. And so we hope that this survey will help inform those efforts so that awareness campaigns increase the equity of use and provide more information so people see 988 as a trusted source when someone is needed in crisis. Thank you.
Thank you so much, Tracy. And what a great way to also get it kicked off with the rest of this. Next up, I believe that I have Miranda Green to talk about the call for presentations for CrisisCon.
Yes, thank you so much. Thank you for giving us a little bit of time today. Hi all. As you said, I'm Miranda Green. I'm from TVD Solutions as well as the Crisis Residential Association, and I'm really excited to share with you all about some changes with CrisisCon this year. So CrisisCon 23 is a little bit different from in the past. The conference is now a joint venture with the Crisis Residential Association, the International Council for Helplines, as well as NASCAD. And starting this year, the conference continues to be focused exclusively on crisis providers and is really intentional about including the full crisis continuum. So that's things like, of course, call centers and mobile crisis, peer respite, crisis stabilization, crisis residential, partial hospitalization, amongst other levels of care that are considered part of the crisis continuum. This year's conference is going to take place in Charlotte, North Carolina this November, specifically from November 13th through 16th. So definitely mark your calendars. But most importantly, what I wanted to share today is that the call for presentations is open and it closes very soon on June 5th. So I would encourage you all to submit a proposal for presentations. If anything within that continuum, it has an area of interest for you. And of note, we want to make sure that crisis stabilization and psych urgent care are well represented. So please consider submitting if that's an area of interest or expertise for you. So thank you again for this time, and I hope to see many of you in Charlotte.
Thank you so much, Miranda. Just a reminder here, as we're trying to get the word out about 988, there's a partner toolkit from SAMHSA that you can get and get all the materials for free. Next slide. In addition, you can, through the Crisis Talk website, get some swag, like a Crisis Jam t-shirt, but also importantly, if you volunteer for the Trivia Hot Seat, you can also get a Crisis Jam t-shirt. All right. And speaking of someone who is already going to get a Crisis Jam t-shirt, Dr. Tia Cole, you are on the hot seat today.
Hey, nice to meet you. Tia Dole, pronouns she, her, hers.
Thank you. Sorry about that.
No problem.
So your question is, the then FCC commissioner frequently referenced a spike in the National Suicide Prevention Lifeline calls in 2017 as part of his explanation for the need for the 988 suicide and crisis line. So who and what?
I think it's B. Sorry.
Oh, you're ready. You didn't want audience help. You didn't want to see a poll.
Okay. Yes, I will get audience help, but that's my first thought.
Listen, go with your gut. Dr. Cole, go with your gut. You came in, Dr. Dole, you came in strong. You came in strong.
Do people answer? I haven't been on the hot seat before.
People are answering now. So in a second, it's going to pop up, but I think you should just go with what you decided. Personally, I feel like when you know it's strong in your heart like that,
there's something, I think something in my tummy feels like it would be like almost like a TikToker kind of sitch. So I'll go with B.
All right, let's see what the audience said. So the audience is with you. The audience, 48% think it's logic. Certainly the mass shootings and the hurricanes, both really significant, tragic events, which certainly also could have had an impact. And a smaller number of folks think the Women's March. So let's see what we have here. All right, Dr. Dole, your gut and the audience were correct. We are all winners in this situation. Congratulations. Thank you.
Thank you. I look forward to wearing my t-shirt.
Next slide. Okay, so this is our quote of the day. And what we have here is in 1999, the New York Times article opened with the US Surgeon General took up a mental health issue today for the first time, declaring suicide a serious public threat. And Dr. Satcher said, the nation must address suicide as a significant public health problem and put into place national strategies to prevent the loss of life and the suffering suicide causes. We must act now. And so that was in 1999. That was really a shift and a beginning of moving towards the national strategy that we're actually going to be talking about today, that Dr. McKeon's going to tee us up for. This is actually we're looking at the third version of that national strategy. Dr. McKeon, I'll pass to you.
Thank you so much. And that was wonderful to start with the visionary work of Dr. David Satcher when he was Surgeon General under the Clinton administration. That was really when the national strategy efforts started, and people like Jerry Reed, who was working for Senator Harry Reid at the time, helped usher through a unanimous Senate resolution that said suicide is a national problem, that it warrants a national solution, and that there should be a national strategy for suicide prevention. And then that led to the 2001 national strategy, the first US national strategy that was then released. That strategy was then revised by the Office of the Surgeon General, working together with the Suicide Prevention Resource Center and the National Action Alliance for Suicide Prevention to issue a revised national strategy in 2012. That strategy, released in 2012, was designed to be a strategy for the nation for the next 10 years. And so if you do the arithmetic, we're now in year 11 since the issuing of the 2012 strategy. So it is now time for a new national strategy to be done. And I'm here to update you on that important work because there is a lot that we have learned over the last 10 years, a lot that we didn't envision at the time. I was involved in the 2012 national strategy, and I can tell you that none of us had any idea that there would be a 988, for example. That the importance of equity is now, so many more of us are now much more aware of the importance of that being embedded in the national strategy. Social media, of course, existed at that time, but its influence has just continued to grow. So there are a number of important reasons for revising the national strategy. But, and I should also mention that this revision is being done directly at the request of the White House. You know, so this was not something that a couple of us thought, well, it's time, let's do it. This was something that the White House Domestic Policy Council has explicitly asked for and was their initiative, and where it will be accompanied by an action plan. But it's also important to realize that the new strategy will be built off of both the foundation of the existing 2012 national strategy, as well as the Surgeon General's call to action to implement the national strategy, which was released in January 2021. And the Surgeon General's call to action pointed out that the 2012 strategy was still relevant and that there had been successes, but that many of them needed to be brought to scale. So the new revised national strategy will really be built on those foundations. Now, in terms of the process that's being used for this, the effort is being coordinated by the U.S. Department of Health and Human Services through its Behavioral Health Coordinating Council's Suicide Prevention and Crisis Care Subcommittee, which in fact just met to talk about exactly this issue in the hour before the crisis jam. And so this group is also coordinating the effort with interdepartmental engagement to build a cross-government strategy. So in this effort, multiple departments outside of HHS have been involved. And the goal is to release the revised national strategy along with an action plan in January 2024, an ambitious timeframe that we are all working on. And so this is the structure for it. The project management team that I spoke of is listed there, all comprised of people who have worked for years in the suicide prevention area in the federal space. And I also want to particularly point out the crucial role of the SPRC and the Action Alliance in this effort, who have been doing a good amount of the writing and the work on external engagement in getting input to the national strategy. And I see Shelby Rowe in one of the little boxes. So I just want to thank her and the whole SPRC and the Action Alliance teams for the incredible amount of work that they have done in helping us try to go with this aggressive timeline. So thank you, Shelby. Next slide. So phase one has been leading the interagency work group. That's the federal government interdepartmental work group, who's been reviewing the 2012 strategy to determine what needed to be updated, refreshed, reviewed the work that had already been done, developing an operational blueprint for the U.S. Department of Health and Human Services, adding a new strategic direction on health equity, and then including content related to youth and social media, substance use, equity, as I said, and 988, and collecting input from inside and outside the federal government. And the needs assessment that has been done has been just amazing. There were over 2,000 responses to the needs assessment that SPRC and the Action Alliance initiated and put together to help give us feedback. We'll be making our first report later today, actually, to the U.S. Department of Health and Human Services and the White House Domestic Policy Council. Next slide. So the interagency work group had a number of different meetings looking at the strategic directions at the issues of substance use, social media, equity, and 988, and also on strategic direction 5, which will be around equity. They were given, the members of the group and the interdepartmental group had been given pre-meeting assignments to maximize the time together. They had facilitated breakout groups to discuss the important issues, and their feedback was used to inform the crafting and updating of the goals and objectives. Next slide. and the SBRC and EDC Action Alliance, in addition to the needs assessment, did an amazing job setting up listening sessions. There were 2 sessions with suicide prevention SMEs, one with equity SMEs, one with lived experience subject matter experts, one with youth and young adults, one with the National Action Alliance for Suicide Prevention Executive Committee, and then the final one yesterday was with the Department of Justice and the Department of Transportation Office of Emergency Medical Services key stakeholders. Next slide. The next step that we'll be moving actively into, starting just next week, is on the development of the action plan, which obviously is to flow from the updated goals and objectives. And the purpose here is to develop a plan that identifies and prioritizes actionable recommendations, and that builds off the updates. It'll be informed by the HHS Suicide Prevention and Crisis Care Subcommittee's work on the operational blueprint for HHS, from information from the other departments, including what are called the sub-IPCs, that's Interdepartmental Policy Councils, run by the White House Domestic Policy Council, which has its own group on suicide prevention that we're connected with, to ultimately come up with the action plan. Next slide. And what I've put here is that you've seen we've done an awful lot of sessions. And this is just to give you an idea of the kind of questions that were posed to people and to pose them to you. And you're welcome to put your thoughts in the chat, because we will review anything you put into the chat today and consider that for input as far as the national strategy is concerned. So usually there's a vigorous dialogue going on in the chat. I would encourage you to do that, taking into account particularly these questions that we were putting to the interdepartmental work group, the subject matter experts, etc. And those questions had been, what have been the most significant accomplishments since the release of the 2012 strategy? What of importance is missing from the 2012 national strategy, particularly given what we know today? How should equity be best integrated into the 2024 strategy? How should youth and social media be integrated into the strategy? The 2012 strategy did not really make a strong differentiation between youth and adults. How should 988 and crisis services be integrated into the strategy? Obviously, question of great interest for this group. And then what should be included in the action plan that accompanies the 2024 national strategy? So I'm going to stop there. That's an overview of where we are in the process to have that's where we are. Those are the kinds of questions we've been asking. We're really heartened by the response thus far. We're going to be continuing to work actively on this. So please put any thoughts into the chat. But also, you can certainly feel free to send suggestions, etc., to me directly if you wish. So I will stop there, and I will turn it over to our roundtable. And I think that is you, Emily.
So much, Dr. McKeon. That was really both informative and very inspiring. And I am just really excited to have the opportunity to share some thoughts. For those who I don't know or who don't know me, I'm Emily Feltrin. I am the Senior Director of Federal Policy and Advocacy with the American Foundation for Suicide Prevention. And AFSP is the nation's largest nonprofit dedicated to saving lives and bringing hope to those affected by suicide.
And for those who may not be as familiar with us, we give those affected by suicide a nationwide community empowered by research, by education, and by advocacy to take action against suicide. And we are the largest private funder of suicide prevention research in the US and globally. And some of you may be involved in your chapters. We have chapters in all 50 states, DC and Puerto Rico, and have lots of community-based programming across the country every year. So under the leadership of Bob Gebbia, AFSP has prioritized DEI within its own strategic plan. And so the comments around embedding equity into the next iteration that we were just hearing about, I think really hits home for me and for AFSP as an organization. Increasing attention to health equity and suicide prevention and really embedding equity in the next iteration will help reduce suicide risk, I think, for marginalized and minoritized populations. So I, for one, am really excited to see equity as such a core component of the development of the next action plan. For some context, AFSP's public policy team in Washington, DC, which is led by our Executive Vice President and Chief Policy Officer, Laurel Stein, who I'm sure many of you know, and of which I'm a member. We're working on many federal and state policies to improve suicide prevention for diverse, underserved, and disproportionately impacted communities and populations. And our priorities have some of the same crossover as to what we were just hearing will be likely either areas of exploration or definitely part of the next iteration. Those for us include research, surveillance, data collection, and infrastructure, as well as access to care and services. And this includes development of 988. I know I saw in the chat some questions around or comments around the need for an awareness campaign for 988 and further development of the crisis continuum, mobile crisis stabilization, all really important, I think, moving forward. And our work also touches on firearms and emergency departments, health systems, and corrections, which I know have been part of past and current plans, as well as maybe part of future iterations as well. So clearly many of the issues being raised in the needs assessments and listening sessions and the questions that Dr. McKeon posed for us, have crossover with many of the issues that we work on. My work within AFSP focuses mainly on federal policy, but we do a lot of state policy as well. And so I think there's just so many opportunities. AFSP is also very focused on being inclusive of all individuals across the lifespan affected by suicide. And as I mentioned, we do have a focus on diverse, underserved, and disproportionately impacted communities, as well as those with lived experience. So I am really excited to see the continued development of the national strategy, as there's just so much work left to be done. And I really do believe we do it best together. And I'm just so inspired by the presentation and really excited to see how this develops moving forward. And thank you so much to the Crisis Jam for having me today and allowing for time for my comments.
That's great, Emily. Thank you so much. If you don't mind, I have one question that I thought I want to dig in with you a little bit. You mentioned just at the start, because this also struck me, that you were excited to see the fact that the focus on equity is a priority in the planning. And I'm just wondering if you had sort of one thing you might say to SAMHSA, not that you only get one chance to say something to SAMHSA, but from your perspective, what could that focus on equity look like? Or what do you think a priority there might be?
I think there are so many different ways I could go with this, but I know for one, we are actually at AFSP working and have this year, especially with our chapters, focused on gender affirming care and other LGBTQ issues at the state level. And SAMHSA just put out a wonderful report on youth suicide prevention among LGBTQIA+ populations. And we're actually getting ready for a webinar partnering with SAMHSA on that for our communities. So I think that's just one aspect of equity and inclusion, and certainly been one that we've seen. And also with the development of the 988 pilot for LGBTQ youth and the partnership with Vibrant and Trevor Project there, I think that there's a lot of ongoing need, clearly, and also opportunity for future and further development in that area. So I know you asked for one, so that's the one I'm going to stick to. But of course, as an organization, we address many, many issues related to DEI, equity. We also work on veterans issues, other populations that are disproportionately impacted. So, but thanks for the question.
Yeah, absolutely. It's an unfair question, but you know how Crisis Jam goes. You've got time constraints, so I want to make sure we're getting everything in. Dr. McKeon, I'm actually going to call you back up because I think you're the both the next speaker, but also just want to flag for folks, as Dr. McKeon did say, please do, and I see you're all putting in questions and thoughts in the chat. That's always a rich place of discussion. And Dr. McKeon, there were a couple of questions that came up. I want to just flag a few, mostly in the order that I saw them. And so one question that came in through the chat, which you may or may not know at this point of the drafting, but will the new strategy include information or logic models to address occupational risks and resources, information for EMS, law enforcement, first responder, layperson, occupation, et cetera?
That's a great question. And while, you know, I can't say what will be definitively in the new national strategy at this point, since we're just finalizing the process of getting information, I really do expect there to be a stronger emphasis on suicide in the workplace, or what workplaces can do as far as suicide prevention is concerned. It's been one of the strongest themes that have emerged from the conversations that we've had. And in fact, yesterday, the listening session that we had through the Department of Justice, who arranged for a variety of law enforcement stakeholders, and the Department of Transportation's Office of Emergency Medical Services, who arranged for a variety of EMS, 911, and first responder stakeholders to participate, really reflected overwhelmingly exactly that issue. And we know that there's work that's gone on in other spheres, for example, in the construction industry. And when we say that everyone has a role in suicide prevention, a lot of work that's been done in schools for youth, etc., the workplace is critical to be, in my opinion, incorporated, into that. So I think that this will, my own opinion, is that this will have a stronger emphasis for sure in the 2024 strategy compared to the 2012, but specific recommendations, are very welcome.
That's great. Thank you so much. And I do just want to flag that you did say people could reach out to you with thoughts. So I just want to remind them that they can both put in the chat, but also reach out to you with thoughts. And before we just move you to the update, maybe I'll take my privilege as the moderator and kind of turn one of your questions back on you, since I've got you here. But you asked the first question, I'm not going to get it exactly right, but what's the most significant accomplishments from since the first strategy, which I think in the beginning I said this was the third, and moving us along too fast. This is the second one. So from the first strategy, and from your perch, from having done this work for a long time, what do you think has really shifted and been the most significant accomplishment?
Well, I would say three things come to mind immediately. So in the 2001 national strategy, there was not a single mention around hotlines or crisis services, nothing in the 2001 strategy. In the 2012 strategy, the lifeline is mentioned and is reflected in a couple of the objectives, but none of us could have envisioned 988 at the time that the 2012 national strategy was done. Also, I think suicide within healthcare systems, which was pretty much silent in the 2001 national strategy, then did it have a significant emphasis in the 2012 national strategy, and really helped to launch the emphasis on zero suicide. I think a lot of important work has been done there. And then finally, regarding community-oriented suicide prevention, I think the SPRC has done tremendous work on looking at what states can do What is the state infrastructure needed for suicide prevention? I think there's been a lot of advances there. And the next step in many ways is how to take the infrastructure that's been built in many states and figure out how to embed that in communities across the country, because ultimately suicide prevention needs to be community driven. So those are some quick thoughts.
That's fantastic. Thank you so much. Well, don't go away, because as I understand it, you're also doing our SAMHSA update for today.
I will be quick because people have heard a lot from me today. So one would be that right after we end today, the 988 tribal grant, we're having its pre-application webinar. So that's at 1 o'clock. It was mentioned earlier, the recent release regarding one of the president's executive orders. But another one on military and veteran suicide prevention has continued to be actively worked on. And I've been particularly involved in a piece looking at embedding evidence-based suicide prevention, including screening, safety planning, and follow-up in community emergency departments across the country, because that's where veterans are more likely to be seen than in VA emergency rooms, most likely. And then finally, just in looking at the Pew report and on the need to continue to get the word out regarding 988, but also the need for more detailed conversations, because the issue about the police keeps on coming up. Our information is that we're talking about 1% perhaps of those that contact 988. But I think if we were able to talk more specifically, it would be beneficial to get a better understanding of what exactly we're talking about. And particularly the distinction between people having suicidal ideation and suicide attempts. If somebody's making a suicide attempt, it's a medical emergency. The National Association of State 911 Administrators have weighed in. Suicide attempts, you go to 911, but we still do get many calls related to that, either from individuals themselves or from family members, about a suicide attempt in progress. I think most people would agree that that requires an emergency response. But suicidal ideation, without behavior, such as a suicide attempt, can typically be handled by Lifeline centers through 988. And I think that's part of the understanding that we need to be able to communicate, better, is under what circumstances would an emergency response, be sent. And so I think that's an important area for further work. So anyway, those are the things that I have. So thank you.
Thank you so much, Dr. McKeon. I think that, addressing that concern really rings true from what I'm hearing in my network. And certainly even if folks hear, less than 1% of calls, they also remember what they hear when they think that when they know that police have been sent and they hear some of those tragic outcomes, they worry. And so it's great to hear that there's a focus on figuring out how to both address that concern and get a better understanding there of what's going on. So thank you so much. Next up, David Miller with the NASHPD update.
Great, thank you so much. NASHPD wants to highlight a very impactful SAMHSA program called the Transformation Transfer Initiative. And on the next slide, you'll see that the TTI, or through the TTI, SAMHSA awards flexible funding to state and territories for innovative work. In the last 2 years, all projects have been around crisis services and 988 implementation. And we hear from our members that these funding sources, the TA that comes with it, has been very, very impactful in closing some of their crisis service gaps and helping them to better position for better 988 positive outcomes. One example in the next slide, you'll see, actually the last year, they awarded 37 awards of $250,000 to state and territories on these areas within crisis services in 988, which is special populations, particularly LGBTQ+ population and American Indian and Alaska Native, workforce development, which is burning everybody's fingertips, and children and adolescents. An example we pulled from this cohort in the next slide is Washington State. They used their TTI to develop and implement a tribal 988 line, Native and Strong Lifeline, which in the last year has been incredibly successful. And they wouldn't have been able to do that without SAMHSA's investment. And pretty much all of the projects have things like this, but we just wanted to give you an example. Last year, or for this year, starting for this fiscal year, again, crisis services 988 implementation, they awarded 50 awards at $250,000 each. Again, it's flexible funding that state and territories are able to use sort of as tipping point funding. And it's amazing what they're able to leverage and what they're able to really paradigm shift in their crisis service space. In addition to workforce development and children and adolescents from the previous year, states were invited to apply for projects that focused on building crisis services in underserved resource minority communities, community trauma and crisis, and certainly looking at better access to community-based mental health services. And the example we picked for this one in the next slide is Oklahoma. And they looked at workforce shortages as everybody, no matter where you are in the nation, it's workforce shortage, workforce issues is really one of the top issues. And Oklahoma saw that in their crisis service space, the two shortages that were really affecting their ability to provide successful services, robust services, were registered nurses and licensed professional counselors. And as they dug a little deeper, they saw that the people in the pipeline to be RNs or LPCs were only like 1 or 2 or 3, maybe 4 prerequisites away from being able to reach that. And for whatever reason, they just had not been able to go over that hurdle. So they used their TTI to work with local universities to take those hurdles down. And what they've been able to see is more are people coming in and being successful in their RNs, coming in and being able to be plugged into their crisis service space, and licensed professional counselors as well. And the impact has been incredible. And they're looking to continue with this with their own state funding because it's been so successful. So again, thank you, SAMHSA, so much for your investments in state and territories and helping us get to where we need to be to have the crisis service system that we know we need to, and make sure that 988 works the way we know it will in the future. So with that, I'll turn it back to you. Thank you for allowing us to come share.
Thank you so much, David. That's great to hear about that resource and to hear about how it's spurring innovation, and particularly innovation that's kind of simple but highly effective in that example that you raised. So appreciate you talking us through that and encouraging folks to look at that resource for their own community. Next up, I have Dr. Amy Cohen and Stephanie Hepburn. Welcome for the crisis talk on SMI Advisor.
Thank you, Aisha. Most of you here know Dr. Amy Cohen. She's the director of SMI Advisor and has hosted the Jam numerous times. Dr. Cohen, unlike many other grants, SMI Advisor has the ability to adapt. Can you share how that's been instrumental?
Stephanie, thanks so much for inviting me on today. I appreciate it. And what a pleasure it was to talk with you a few weeks ago. So SMI Advisor is really grateful that SAMHSA had the foresight when they developed this grant to think about the fact that if our mission is to serve the teams who care for those with serious mental illness, we're going to have to be able to pivot all the time. It's going to be an ongoing conversation between the field and us on what they need. And so, the most recent big example of that, of course, is COVID, right?
Mm-hmm.
So when COVID happened, it was like, what are we going to do? People are clients aren't coming into the clinics. People are showing up at the ER with maybe active psychosis, and then they're tested for COVID and they're turned away because they don't have protocols for how to treat both. Prescribers were worried about how to handle certain medications while also giving someone Paxlovid. And so we really tried to pivot and build a resource hub around all the things we needed during COVID, things about medication, things about how to combat client loneliness who weren't able to get out, how to take care of ourselves during this kind of different way of providing care. And so I think, I mean, that's a major example, right, of being able to pivot. But I think as we talked when we talked a couple of weeks ago, it really is an all the time pivot because fundings change, workforce changes, what clients' needs change. And at SMI Advisor, we really try to kind of have our ear to the ground all the time. We have a consultation service where people can write in any kind of consultation that they want. And we answer in 24 hours, and those give us information. What are people asking about? What do they need? We also have a contact us where people write in and say, hey, I wish you would do this, or I really need this, or why don't you do more for social workers? And then we're like, oh, we need to do that. And so in many ways, SMI Advisor is a ship that's in an ocean, and the ocean's filled with all of our care teams who are kind of guiding the ship to where we need to go. And I really appreciate that because I feel like we actually can make an impact then, right? And SAMHSA just really had that foresight and the trust in us that we would truly listen so that we could make a great impact. And for that, I mean, I'd say it's probably the best job I've ever had.
When you talked about pharmacists, and I thought that was really interesting because you paralleled what happens in other countries and the role of pharmacists and how during COVID, they really had to pivot in terms of the role for the pandemic, but also for mental health. Can you talk a little bit about what you see on the horizon for pharmacists?
Yeah, I mean, for me, I worked in the Department of Veterans Affairs for 18 years, and pharmacists were really, truly embedded on the clinical care teams when we were caring for those with serious mental illness. Additionally, as many of us know, when you travel in other countries, the pharmacists are the first place you go and you say, I have an upset stomach, and they tell you what to give. You don't necessarily go to a primary care provider first. And we're noticing that more places are adopting models where pharmacists are embedded on teams. They're not prescribing, but they're actually delivering, and they have a lot of face-to-face contact with clients. And we foresee on the future horizon, people who are stable on medications, maybe long-acting injectables or other medications, they might be getting their refills and their shots at CVS or Target or Walgreens. And so we really, first of all, it extends the workforce, right? It's another place for individuals to go to have a voice to talk to. As we know on our care teams, there might be one person who really resonates with us, that we really feel like gets us. And so it's another chance to have another person on the team who might get them and understand them. And so at SMI Advisor, we're really kind of bringing pharmacists into the fold and consider them part of the care team. And this year, for the first time, we're going to start offering pharmacist CEs for the first time for free. So again, really excited about what's on the horizon.
And Dr. Cohen, I have one more question as a little bit of
Stephanie, I'm so
yes.
sorry.
Oh, okay.
I've got to move us
No,
along.
I understand.
No problem.
You mean I can chat for a long time.
Stephanie and I'll chat offline.
Yes,
Thank you.
And also, I do want to flag, there is another question for you in the chat, Amy. So if you do have a chance to respond, they're great.
Thanks, Aisha.
So thank you both. Thank you so much. So the next, I'd like to bring up Stephanie Mitchell-Hughes for our lived lens perspective to really talk about, I think, what is the overarching theme of these crisis jams, that the launch of 988, kind of where we started, that's not the end of this journey. We're really looking to try to get to the top of the mountain where we have a crisis system that's effective and flexible and oriented around the dignity of the people that it's supporting. And, Stephanie, from your perspective, we'd like to hear sort of how you know when we're at the top of that mountain. What would it look like?
Well, thank you. And thank you for having me or inviting me to participate in today's Crisis Jam. Just based upon my own personal lived experience, because I am someone who lives with depression and suicidal ideation, I will know that 988 is successful because I will not be concerned or think twice about calling for emergency services or support if I needed them. For me, I've worn many hats. I'm a lawyer. I am now a solo mom, semi-empty nester. But when I look back and I think about the years and even within the last few weeks where I was really struggling because at least a few weeks ago, I needed to change or decrease a medication dosage, I always think twice about going to the ER to get assistance because I know that if a professional determines that I am a danger to myself or even possibly someone else, even if I don't perceive myself as such, that they can place me on a hold. And rather that, because the options that are available are limited and there's only and has always been this one paradigm way of responding to individuals who find themselves in crisis. And for me, particularly in my years as a solo mom, I would not have been able to be admitted to a hospital and then leave my children behind. It would have just put them in a state of crisis and really amplified my circumstances and their circumstances even more. And so for me, I just did not reach out for assistance and for help. I've lived with depression and with what I call generous helpings of suicidal ideation for over 45 years now. And so I know and have what I call white knuckled my way through a number of different crises and circumstances. But I will know that 988 has achieved its goal when I truly have someone to call, somewhere to go. And I know that I'm going to have people who are trained on how to respond to me if I am in need of assistance without immediately jumping to either one, admitting me to a hospital or calling law enforcement.
Stephanie, thank you so much. You can see in the chat how much your story is resonating with everyone. And I just want to say thank you for sharing and for putting that charge in front of us and that goal of making a system where you do not hesitate, as you said, you do not hesitate to call and you do not have to white knuckle through your own struggles alone. So thank you so much.
You're welcome. Thank you again for having me.
Next, I would like to call up for our state updates, Shelley and Stephanie. You here?
Yeah, this is Stephanie, Aisha. Thank you.
Great. Thank you, Stephanie.
Yeah, so for a state legislative update, we are hitting that time of the year where a lot of states are actually wrapping up their yearly sessions. So over the next few weeks, expect some color changes to this map. This week, some changes you'll see. You will see Minnesota now in the gold color because they are officially the 6th state to authorize a 988 telecommunications fee to help sustainably fund their 988 call centers there. That was signed last Wednesday. So I just wanted to also take a moment to say a huge congratulations to NAMI Minnesota, Mental Health Minnesota, and the whole Minnesota Mental Health Legislative Network that fought for that bill. Also, compared to last week, you'll see that Texas is now gray because they are out of session. Their 988 bill unfortunately expired, but on a positive note, I just wanted to say also with Texas, the budget agreement that the lawmakers came to did include some new funding for crisis stabilization facilities, crisis respite units for youth, and youth mobile crisis outreach teams. And just quickly, we have one more update on Pennsylvania, but I will turn to my colleague Shelley Polanco for that.
Thank you, Stephanie. Just quickly, Pennsylvania's House and Human Services and Veterans Affairs an Emergency Preparedness Committee will be having a joint hearing on June 5th on crisis services. The committee is asking for testimony, so if anyone is interested and the parties to speak on the needs of the crisis services or are in support of the 988 fee. So they are introducing a fee in Pennsylvania of 6 cents for the telecom. And if you guys are in support of that, they are taking testimonies up until Friday. And we can provide more updates on the bill once that bill is released. That's it for now.
Thank you so much, Stephanie and Shelley. And great to hear about some of those big wins and also some of the areas where there's still continuous work. So our very last speaker, Vic Armstrong, I'd like to call you up to bring us home.
As we bring the month of May to a close, we mark the end of Mental Health Awareness Month. But May also marks another historical event. On May 25th, 2020, George Floyd, a 46-year-old Black man, was murdered in Minneapolis, Minnesota by Derek Chauvin. In the ensuing months, we watched as the images flashed across our television and computer screens endlessly. Not only the images of George Floyd lying on the concrete with an officer's knee on his neck, with the sound of his voice as he called for his mother, but also the images of protesters and rioters and a divided America. I remember personally experiencing deep emotional pain as I watched the chaos unfolding in Minneapolis in the aftermath of his death. I had a sea of emotions swirling inside me, including sadness, anger, frustration, and fear. Not fear for myself or my own safety per se, but fear for my sons, and perhaps even for the soul of America. I feared and continue to fear for the emotional scars we have created, a collective trauma we all carry, albeit some carry differently. You see, I was not raised on the mean streets of Minnesota or New York or LA or Chicago, or even Charlotte. I was raised on dirt roads in rural North Carolina. I didn't grow up running from street gangs or having to fight my way home from school. I grew up working in tobacco fields and playing outside with my siblings. I didn't come home to an empty house or have to wonder if there would be food on the table. I was raised by two loving parents, one a preacher and the other a school secretary. I never knew George Floyd. Still, I experienced trauma that I still carry. And should I ever be in need of your services, I will bring that trauma with me. Let us not forget that for many, the emotional scars of the death of George Floyd, or the violence against Asian Americans, or bigotry against Jewish Americans, or hatred toward LGBTQ Americans still prominently remain with us, as does the accompanying sadness, anger, frustration, and fear. On the heels of Floyd's murder, we saw an attentiveness to equity, the likes of which we had never seen. We saw political will to address inequity and make equity a cornerstone of mental health care. Most recently, however, we have begun to see a waning of that political will. And for many from historically marginalized communities, there's a fear that equity may be written off as a trendy topic. Regardless of whether equity is all the rage, or a trendy topic, or politically toxic, let us not forget that individuals experiencing mental health emergencies, above all else, need to be met with humanity, empathy, and humility. The many who find themselves in need of our services often carry scars we cannot see and come to us not only to help them restore their cognitive and emotional well-being, but to help them find hope and connection in a world that many of them may feel does not recognize their humanity. That is their reality. That is our challenge. And that is Strong Talk.
Thank you, Victor. That is a powerful challenge and a powerful reminder about the importance of not letting this moment slip away to address equity and to really address the real trauma that many in the communities of color do experience. Thank you.
Thank you.
So just a reminder, you can find the Moving America's Soul and Suicide on YouTube. And then coming up, we have several great sessions. Next week, we have the Safe Utah with Representative Eliason from Utah to talk about their crisis chat and tip line. And the following week, we have Susie Reese from SPRC to talk about the lived experience initiatives. Thank you so much for being here today. And we will see you next Wednesday. And thank you to all of our speakers as well.